Hi, my name is Mackenzie. I'm a consultant in emergency medicine based at Addenbrooke's Hospital in Cambridge. I've been asked today to talk to you about trauma team leadership. That sound. How do you feel about that sound? For some of you, you'll feel threatened by it. For others, you won't feel threatened by it. You'll be challenged by it. You'll be thinking ahead and anticipating what may come next, but you're not threatened by it. We need to work out how to move from a threatened to a challenged mindset. And there's really a number of ways to do that. Obviously, one is attending talks like this and understanding a little bit more about trauma team leadership, but other ways include having really established, clearly defined processes in your department, in your resuscitation room, for what happens when that phone rings. Part of being in a challenged mindset rather than a threatened mindset is about understanding and being comfortable with all of the equipment, all of the processes that you may need to use and follow in the course of your management of the patient. If you don't know what the anticipated clinical course is likely to be, then you'll feel very anxious about that. Some people refer to that as the 0-point survey, but of course it doesn't just apply to the phone ringing, it applies to the day, the duty period, as it were. So understanding exactly what happens when the phone rings, understanding what the equipment is, what the roles of staff are in the pre-arrival phase, and understanding that you, right from the outset, as the putative trauma team leader, need to be in the right mindset yourself. You need to be adequately rested, you need to be able to devote your energy to the management of this trauma team. The next thing we often do is then activate the trauma team. Now, major trauma is a rare event. We see 3 to 5 major trauma patients a day in our department. We're a regional major trauma centre covering 20,000 square kilometres, about 6 million people, with 12 acute hospital trauma units feeding into us. So that's not many patients. It's less than 1% of our daily activity, and half of those patients are secondary transfers. So our individual exposure to these patients is low. So we're never going to be really comfortable or really drilled or rehearsed with them unless we drill and rehearse to receive them. So major trauma is a rare event. In my institution, we have over 10,000 staff. So when we activate the trauma team, I don't know whether it's an anaesthetist, a general surgeon, an orthopedic surgeon, a pediatrician, an emergency medicine resident or nurse that I've worked with before or know and understand or not. In fact, most of the time, there'll be at least 2 or 3 members of that trauma team that I will never have met before, and they will never have met me. So major trauma is a rare event. And the trauma team, as it forms, is not really a team. It's not a team in the conventional sense of a group of individuals with a really clearly defined shared mental model and goals, who know each other's capabilities and limitations and have worked with each other in previous occasions and drilled and rehearsed. We are not the string quartet. We are not the champion football team. We are not the elite group of special forces, no matter how much we may want to learn from those organizations or how much we may aspire to be like them. Our team is actually not really a team. It's what I call a flash team, meaning it is formed of groups of strangers who are pulled together with a series of actually shared responsibilities or requirements, but a very wide variation in their comfort. In fact, whether or not they're in a threatened or a challenged mindset will be very variable. And therefore, in that setting, rare event, flash team, actually, I'm sorry to say, it's all down to the leader. It's all down to you. You are the trauma team leader. You are responsible for ensuring that this disparate group of people are able to give of their best in the management of this really sick patient who may have any of the full spectrum of major trauma injury presentations.
Addenbrooke CD, pass your message.
So what do I actually do? Well, I know that I've got to take control of this group of people. I've got to be assertive, but not overbearing. I've got to be really obvious as the team leader. So the first thing I do before I call the team is identify myself. I make sure that I am in a prominent place in the department and I am ready to receive members of the trauma team as they arrive so that I can intercept them, introduce myself, say, hello, I'm Rod, I'm the consultant trauma team leader. What's your name? Great. What's your grade and specialty? Great, thank you very much. Can you now put a gown and a label on, write your name on it, and then come back into the bay, start thinking about your equipment before I brief everyone together. Thanks very much. Straight away, just with that introduction, I have asserted myself as, first of all, someone who's not threatened, and secondly, as the leader. Once the team is formed, if I've got time, and I normally would mobilize a trauma team 15 to 20 minutes before the arrival of the patient, if I have the opportunity to do so, because that's how long it takes to form a flash team. I will then call everyone together and I'll say, everybody who's here as part of the trauma team, please come towards the bay so that I can brief you all. I'm being, again, quite assertive. And sometimes, particularly for people who may struggle with that, that needs practice. You need to project yourself like an actor would. I need to very quickly understand who's who and what their capabilities are. So I'm going to say, okay, everybody, this is the trauma team. We are expecting, and then I'll tell them what we're expecting. And then I'll say, what I'm going to do is make sure that we all know each other's names and roles. So we're going to go around the room and clarify those things. And then I'm going to talk through what I expect to happen in terms of the anticipated clinical course. So I am conducting this orchestra. I am controlling the flow of information and I'm making sure that I'm the focal point. Everybody has communicated with me and everyone's starting to get a little bit more comfortable about the fact that actually, you know what, we are starting to form a team. We're starting to develop confidence in each other. There is a point with all trauma team briefings where I call it cat herding, where everyone's busy. So everybody has received their initial brief, but they distracted. So they go off to answer phones, or they might nip round and see another patient, or they might do something to just keep on top of the daily business. So one way of controlling that and doing a very important thing, which is to focus people on the patient that's arriving, I do what I call catastrophizing. So what I then do is I say, okay, everybody, we've got a few minutes before the patient arrives. We're comfortable, we've got all the key people and we've got the equipment and we're ready to receive the patient, but let's just talk through the worst case scenario. And people look in, and if they're not looking in, I tell them to look in. I'll say, can you just keep in the team for the moment. Let's just talk through the worst case scenario. So what is the worst case scenario? And you might hear nothing at all. People don't really want to speak up. Or you might hear somebody say, well, an obstructed airway. And I'll often then say, well, actually, that's not the worst case scenario from my perspective. What is the worst case scenario? And someone might say, well, uncontrolled bleeding. And I might say, well, yeah, we'll talk about that in just a moment. But what I'm most focused on right now is what happens, what do we do as a team if this patient arrives in cardiac arrest? That wakes people up. There's often a palpable change in the room when I ask that question. And it's a great opportunity to then do a micro teaching session of the HOT principles. A micro teaching session which gives people confidence in me, it gives people confidence in their ability, but also gives them the opportunity to make sure they've got backup and help, because actually, you know what, they're not very confident about this. So I will say to the team, the worst case scenario is this patient arrives in cardiac arrest. They're on the ambulance trolley, they've just arrested, what are we going to do? And then start interacting with the team members in a structured way to run through the traumatic cardiac arrest flow or protocol. Now, this isn't a lecture on the management of traumatic cardiac arrest, and and many of you will have experience of that. But the point I'm trying to make is that this is an opportunity to get everyone on the same page, to get everyone now starting to share a mental model of whatever it is that we might be facing. We can talk through anticipated clinical course, and we can talk through clinical treatment plans. And the more opportunity there is to do that as a team, then the more opportunity there is for people to get more comfortable. And if we take the traumatic cardiac arrest example, one of the things I often do with my surgical colleagues is I'll get to the surgical resident and say, if we need to gain surgical control of the aorta very quickly, are you comfortable about being able to do that? Now the answer is often no, in which case I say, please give your boss a call and then make sure you've got the equipment available should you need to do that. So you can see how this catastrophizing is a really useful tool for getting everyone focused on what lies ahead. Let's return to the case that started the day. Road traffic collision. Person reported trapped. Pregnant patient. A lot of things suddenly to be thinking about in our pre-arrival procedures. Not just mum, who's going to require potentially the full spectrum of resuscitation, but actually we may need to be undertaking a resuscitative hysterotomy in the emergency department. We may need a rapid transition to theatre for emergency caesarean section, or that may need to happen in the department. We may need a neonatal resuscitation team, and that resuscitation may be complicated by prematurity. A lot of things to think about in that preparatory phase, and so my mental checklist is expanding. But this is where readiness, leadership, and a challenged mindset converge. I can control how prepared we are when that trolley, when that patient comes into the resuscitation room. That's what turning threat into challenge looks like in practice, taking a situation that feels overwhelming and breaking it down into something that is organized, structured, and manageable, and ideally drilled and rehearsed. When that trauma team form and I start briefing them, and that patient comes through the door, there is no one leadership style that works for everybody in the room. Each of those team members will arrive with a different level of readiness, what the model calls developmental levels. I prefer readiness. Some are highly competent and highly confident. They need space to get on with their responsibilities and their duties. Others are competent but anxious, or junior and inexperienced. Some may have great technical skills but very little exposure to this sort of case. My job, your job as trauma team leader, is to read the room, starting in that team brief, and move quickly and dynamically between the four leadership styles: directing, coaching, supporting, and delegating, according to each person's readiness and the readiness of the team as a whole, or the tribes within the team. Now, in the first few minutes, and sometimes in the few minutes before the patient arrives, leadership tends to be more directive, clear, concise, task-focused communication. That's partly to get things going, but it's also partly to test the room to see how people are responding to being directed in this way and whether that's what they need. It brings clarity and it maintains tempo. But as the situation evolves, I'll frequently move towards a coaching and supporting leadership style, and that might be broken down depending on what the particular needs are and the particular task is. So I'm constantly trying to get feedback from the team members. It's really part of what that briefing was all about, and the catastrophizing and getting a sense of where people are, especially if I don't know them, to try and understand, including in the first few minutes of directive leadership, where they are in terms of readiness. When the team is functioning really well, I can focus on the medicine. I can actually not worry too much about the functions and tasks, the practical, if you like, technical tasks around resuscitation, but be thinking much more about physiological derangement, much more about damage control resuscitation strategies, much more about, for example, what's happening with my gases, what's happening with my coagulation, and where are we with blood volume replacement, and so on and so forth. So actually, the sooner I can move away from a directing leadership style to a more delegating style, the better for me and the better for the patient. But I may not be able to do that. It's all about who shows up on the FLASH team. You can see that trauma team leadership is 90% communication. It's the communication skill set that really sets aside an effective trauma team leader. And that skill set isn't just about the leadership styles, it's about how those leadership styles are communicated, how that communication takes place between and within the team. And there are two particular techniques within the wider realm of communication that I think it's important for trauma team leaders to master. And there are lots of different models out there for conceptualizing these two techniques, but one is often referred to as graded assertiveness and the other is conflict resolution. There are a number of graded assertiveness tools that are out there, but there's no point in you using one that isn't the same one as the one used by the hospital you're working in. Similarly, there are a wide range of conflict resolution concepts. I will often recognize that conflict is more a manifestation of a stress, or it may be a manifestation of real anxiety or concern about the care or condition of the patient. So if I recognize that the communication is perhaps breaking down, or there is conflict or disagreement that is emerging, what I need to do is apply a conflict resolution sequence, and that usually in my practice starts with pausing the noise, then restating the goal, and then reassigning or clarifying. Now, the aim isn't to win the argument, it's to restore coordination, situational awareness, and restore tempo. And if it means I have to change my priorities, then I'm perfectly happy to do that. That's leadership, not giving orders, but maintaining communication when pressure fragments it. My best friend in the trauma team is this clock. It's really important, this clock, because this clock allows me every 5 minutes to remind myself to do a micro summary out loud for the whole team. The clock is a great opportunity or a great tool to help you manage the tempo of care. So to summarize, my top tips for the trauma team leader are: number one, move from a threatened to a challenged mindset. Number two, recognize that in order to do that, and because trauma is a rare event, you're going to need to drill and practice and rehearse. Number three, recognize that your trauma team is always going to be a FLASH team and therefore won't have all the attributes of a high-performing team unless you as the leader start to instill or develop or demonstrate some of those attributes. Number four, to assert yourself as a leader very early on in the formation of that team. Number five, catastrophize. Use that as a means of developing a shared mental model. Use that as a way to help your team members move from a threatened to a challenged mindset. Number six, develop an understanding of situational leadership concepts and practice being able to move from more assertive to less assertive leadership styles. Both linked to that, number seven, develop comfort or confidence in graded assertiveness. Linked to that, number eight, develop comfort or confidence in conflict resolution. Situational leadership, graded assertiveness, conflict resolution, these are effectively communication skills that you as a leader can read around, develop, practice, rehearse, and drill. Number nine, the clock is your friend. Use the clock as a means of maintaining tempo, but also maintaining situational awareness by micro summaries at regular intervals. And number 10, look after yourself. Moving from a threat to a challenge mindset is about using every experience you have as a trauma team leader to further develop you as a trauma team leader. Well, the clock tells me I'm out of time now. I'm sorry I'm not there in person to be able to talk through specific circumstances or address any questions or comments you may have. I hope that's been useful. Please don't hesitate to get in touch with me if there's anything you want to talk through further, or if there's any resources or material that I've touched on that you'd be interested in having a look at.